Thank you, Abhinava. So we are starting. Our presentation is on transfusion of blood and blood products. So our objectives for this presentation, the first one, we are going to introduce you on blood and blood composition, then history of blood transfusion, functions of blood, blood products and how they are obtained, indications of blood transfusion, process of blood transfusion, complications of blood transfusion, and lastly, guidelines for blood transfusion. Without wasting time, let's start on the introduction. So blood is a connective tissue fluid consisting of plasma and cellular components. So the plasma constitutes 55%, and we also have the formed elements, the white blood cells, the red blood cells, and the platelets, which constitute 45%. So the plasma proteins, we have the serum albumin, we have the serum globulin, we have the fibrinogen. So the serum albumin constitutes 4.7 gram per deciliter. Then the globulin constitutes 2.3 gram per deciliter. And fibrinogen constitutes 0.3 gram per deciliter. So the plasma also constitutes of the inorganic elements, that is the sodium, potassium, magnesium, chloride, and calcium. And it also constitutes of the organic elements. That's why we have the fats, the proteins, the carbohydrates, and the amino acids. So what is blood transfusion? Blood transfusion is the process of transferring blood and blood products from one person who is a donor into the circulatory system of the other who is the recipient. So let's look at the history of blood transfusion. So back in the days in 1492, Pope Innocent VIII suffers the stroke and receives blood transfusion from three 10-year-old boys. So Pope and the three boys, unfortunately, they all died later in that year. Then in 1665, Richard Lower in Oxford conducts the first successful canine transfusion. Then in 1667, Jean-Baptiste Denis reports successful sheep human transfusion. He transfused blood from the sheep to the human. Then in 1678, there was animal human transfusion, but it was banned in France because of the poor results. Then in 1818, James Blundell performed the first successful documented human transfusion in a woman suffering postpartum hemorrhage. The donor was the husband, and she later survived. In 1901, Karl Landsteiner, that we all know about, discovers the ABO system. Then in 1914, the Belgian physician Albert Hastings performed the first non-direct transfusion using sodium citrate as the anticoagulant. In 1926, British Red Cross instituted the first blood transfusion services in the world. In 1939, there was razor system identification and recognition. So we go to the functions of blood. We know that this blood is important in transporting oxygen from the lungs to the tissues. Then it's also important for transporting products of metabolism to the liver, to the kidneys for excretion. Then we also know that blood is important in transport of hormones to their target organs. Then it's also important as it has a nutritive function in that it gets glucose from the GIT digestive system and distributes it to the tissues that require it. Then it's also important in protection and body defense because it constitutes that immune cells, the white blood cells, and also the platelets, which are important in protection and body defense. Then Blood is also important in body temperature, blood pressure, and also pH balance. Then also blood is important as a storage media in a way that it constitutes those electrolytes, the water, the proteins, and in case of scarcity, then it can give out those products to the tissues that require them. So we are going to now the blood products. These blood products, they are defined as any part, sorry, as any product of blood which is collected from a donor for use in blood transfusion. So these blood products include the whole blood, packed red cells, fresh frozen plasma, cryoprecipitate, platelets, prothrombin complex concentrate. So sources of blood include different types of grafts. We know we have the allografts, the xenografts, and the autografts. The allografts, that is where the donor and the recipient are of the same species, like from human to human. Then for the xenografts, that is where the donor and the recipient are of different species. For example, you can get from sheep to human. Then for the autograft, that is from the recipient is considered the source, is the person that gives out that to themselves. Yeah, so the recipient is considered the source in which a tissue is transferred from one part of the body to another, but still on the same human being. So we go to the whole blood, still under these components of blood. So we are going to break them down. So we are starting with whole blood. So whole blood is unmodified blood after it has been picked from the donor. Before you separate it, when it's still whole, that is whole blood. It is now rarely available in practice because component therapy, such as packed red blood cells, make more efficient use of limited donor resources. Because now if we are to transfuse whole blood, we may run short of these of the blood because we are transfusing everything, but some patients require specific components of blood. However, it has a significant advantage over packed cells as it has the coagulation factors. It's so rich in those coagulation factors, and if it's fresh, it's also metabolically active than the stored blood. So this whole blood, it is stored at 2 to 6 degrees Celsius. So we got packed red cells. These packed red cells, they are obtained by centrifuging whole blood, and we centrifuge this whole blood at 2000 to 2300 grams for 15 to 20 minutes. Yeah, so after centrifuging, that's where we separate the layers of this blood. We get the red cells packed down, then the buffy coat, then the plasma, and the platelets on top. So it can be stored for 35 days at a temperature of 1 to 6 degrees Celsius. So 1 unit of blood, 1 unit contains 300 mils with hematocrit of about 70%. 1 unit raises the hemoglobin percentage by 1 gram per deciliter. So these packed red blood cells, they are indicated in chronic anemias, for example, in old age and in children, like the aplastic anemia and also the thalassemias. It's also indicated for blood loss during surgery, and is also indicated in hypovolemia due to hemorrhage. It minimizes the cardiac overload after transfusion. Remember, if you transfuse the whole blood, you're going to increase the volume. But then, if you transfuse only packed red cells, you're going to increase the volume of these red blood cells. And remember, these red blood cells are the ones that carry the oxygen. So we are not going to have the cardiac overload. So we got fresh frozen plasma. It is obtained in the same way as the packed cells by centrifuging the platelet-rich plasma after packed cells are removed. So you refrigerate, you freeze this platelet-rich plasma, and that's why they call it fresh frozen plasma. So you put it in the fridge, and when you freeze it, you increase its shelf life. So it is stored at negative 40 degrees Celsius, and it can be stored for 2 years. It contains all coagulation factors. That is very important. This fresh frozen plasma contains all the coagulation factors. So it is indicated in severe liver disease. Remember, these coagulation factors are manufactured in the liver. So if you have a liver disease, you're not going to produce these coagulation factors. So you're going to transfuse the fresh frozen plasma. So it's indicated in severe liver disease with abnormal coagulation function. It's also indicated in the congenital clotting factor deficiency. It's also indicated in thrombotic, thrombocytopenic purpura, also disseminated intravascular coagulation, and also in massive transfusions. Then, rhesus D positive fresh frozen plasma can be given to the rhesus D negative women, although it's possible for seroconversion to occur with large volumes owing to presence of red cell fragments, and also we have to give rhesus D immunization to prevent that. So we go to the cryoprecipitate. Cryoprecipitate, it is a supernatant precipitate of the fresh frozen plasma. When you thaw that fresh frozen plasma, you get that supernatant, which is the cryoprecipitate. And that cryoprecipitate, it is rich in factor VIII, mainly fibrinogen, factor 13, and von Willebrand factor. So this cryoprecipitate, we store it at negative 30 to negative 40 degrees Celsius and with a shelf life of 2 years. So the cryoprecipitate is indicated in inherited deficiency of factor VIII, factor 13, von Willebrand factor, and fibrinogen deficiency. Let's go to platelets. So they are supplied as pooled platelet concentrate. What they mean by pooled platelet concentrate is it means that they get the platelets from 4 to 5 individuals. They bring the platelets together. So they call that a pooled platelet concentrate. And it contains about 250 to 10 power 9 per liter. So platelets are stored on a special agitator. Why they keep them on that special agitator is to prevent clamping of these platelets at 20 to 24 degrees Celsius, and they have a shelf life of only 5 days. You see, they have less shelf life because they are kept at room temperature, and we know at room temperature most of the bacteria can end up invading. So the shelf life of these platelets ends up to be less of about 5 days. So they are indicated in patients with thrombocytopenia, platelet dysfunction, who are bleeding or under surgery. Patients on clopidogrel, we know clopidogrel is an antiplatelet drug. So if patients are on that drug but they are actively bleeding, we give them these platelets. And also those ones undergoing a major surgery. So there is another component of blood. We have the prothrombin complex concentrates. So these are highly purified concentrates. They are also prepared from the pooled plasma. So they can either be a 3-factor or a 4-factor. So a 3-factor PCC, that is prothrombin complex concentrate, they contain factor 2, factor 9, and factor 10. Then the 4-factor PCC contain factor 2, factor 7, factor 9, and factor 10. So the difference between the 3 and the 4 is the factor 7. So these are indicated for emergencies emergency reversal of anticoagulant warfarin therapy in uncontrolled hemorrhage. So we have the general indications of blood transfusions. Why do we give these blood transfusions? So we give these blood transfusions in acute blood loss following trauma. If a patient loses more than 15% of the total body volume, we are meant to give them blood transfusion. So during major surgeries, for example, the abdominoperineal surgery, the thoracic surgery, the hepatobiliary surgery, we are give because they lose blood, they lose very considerable high amounts of blood. They are meant to also get uh, blood transfusions. So also following several burns, because we know these severe burns, they damage the endothelium of the blood vessels. So they end up losing a lot of plasma, a lot of blood. So they are indicated for blood transfusions. In septicemia, as a prophylactic measure prior to surgery. So they also give this blood to prevent, or a prophylactic measure before surgery, so that the person does not lose a lot of blood and perhaps maybe blackout. So we have whole blood is also given in acute blood loss. Then packed cells are usually given in chronic anemias, in old people, in children, in people with thalassemias. We usually prefer packed cells. Then those blood fractions are given in ITPs, hemophilias. Yes, but we have the specific indications of these blood product transfusions. So when we give the packed red blood cells, when we give platelets, fresh frozen plasma, and all. Yeah. So in packed red blood cells, we usually give them in hemorrhagic shock. But in hemorrhagic shock, we don't only give packed red blood cells. We can either give them. We can give. Uh, in hemorrhagic shock, we can give red blood cells, we can also give platelets, we can also give fresh frozen plasma. Why? Because these people have lost so much blood. And remember, the blood constitutes of all these. So if we only give packed cell volume, that means if we only give packed red blood cells, that means we are going to dilute the platelets that are there. We are going to also dilute the plasma that they have. So in hemorrhagic shock, we give packed red blood cells. We also give platelets. We also give fresh frozen plasma. So also in anemias, we give packed red blood cells. Platelets are also given in thrombocytopenias. Then fresh frozen plasma is given in liver cirrhosis and also DIC, disseminated intravascular coagulation. Then the 4-factor prothrombin complex concentrate is given in the warfarin toxicity, and you give it alongside vitamin K. So we also have the cryoprecipitate. The cryoprecipitate can reduce, or the cryoprecipitate can be given either you have a high loss, you've lost so much of the plasma, or increased consumption of the fibrinogen. I've told you before that cryoprecipitate is highly rich of fibrinogen. So if you've overused up the fibrinogen, or you've not produced sufficient fibrinogen, then you are eligible to be given the cryoprecipitate, and it's usually given in postpartum hemorrhage, in the ruptured ectopic pregnancies, in massive bleedings, and also in the disseminated intravascular coagulation. So we have the perioperative transfusion criteria. So red blood cell transfusion criteria. If the patient's HB, hemoglobin is less than 6 grams per deciliter, then they have a high possibility that they are going to benefit from this transfusion. But if their HB is between 6 to 8 grams per deciliter, the transfusion is unlikely to benefit them if there is no bleeding or impending surgery. So they may not benefit from you transfusing them with these red blood cells. Then, if the HB is greater than 8 grams per deciliter, there is no indication. We do not need to transfuse them with these red blood cells in the absence of the other factors like bleeding or surgery awaiting. So we do not need to transfuse them if they have HB greater than 8 grams per deciliter. So we go to the process of blood transfusions. So in this process of blood transfusion, we are going to first select our donor. So the donor selection is based on medical history and few routine physical examinations. For example, the weight. If someone is going to donate blood, their weight should be greater than 45 kilograms. Their blood pressure should be in normal range. Their temperature and hemoglobin should also be in the normal ranges. And these are done to know whether the donor is suitable for donating blood. So the donor should be healthy. There are 3 types of donors. We have the voluntary donor, someone who is willing to donate their blood. Then the replacement donor, these are people in the communities who give their blood to the blood banks. And we have also the professional donors. These people donate blood with interest of having money. They are given money to donate blood. Yeah, so it is important to know whether the patient has a history of diseases like the hepatitis, the AIDS, the syphilis, and if so, the blood should not be obtained from them. In the blood bank, the blood is routinely screened for these infections. So we got collection of blood. So blood is collected under aseptic conditions using a sterile plastic bag with the anticoagulants. Now they usually use that CPDA, which is the citrate phosphate dextrose adenine. It's the most commonly used anticoagulant. So you mix the blood with that anticoagulant gently and periodically during its collection. So the anticoagulant used, the different anticoagulants are available. We have the citrate phosphate dextrose, the CPD. We also have the CPDA1, which is the citrate phosphate dextrose adenine. Then we also have the acid citrate dextrose, but this one is not used nowadays. Then dextrose is used for ATP generation for the viability of these red blood cells. Then the adenine is a substrate for the red cell synthesis of ATP. Then the citrate, we know it chelates calcium, so it prevents clotting. Then we have sodium biphosphate. It buffers the end products of glycolysis. Then storage of blood. Blood is usually stored in the refrigerator at 2 degrees to 6 degrees Celsius. Then we have a pre-donation checkup. Before you donate this blood, we have to do certain checkups. So on the donor blood, there are tests that are routinely carried out. We have to also ensure that the weight of the donor is in the normal, it should be more than 45 kilograms. Then we do the ABO and rhesus groupings. Then we also test for the hepatitis surface antigen. We also test for the anti-hepatitis C virus. We also test for the anti-HIV-1 and also the anti-HIV-2. And we also do the serum alanine aminotransferase. So we also do the malaria and the syphilis. Then in the recipient's blood, We also do the ABO and the rhesus grouping in the recipient's blood. Then we have the compatibility testing. Still before transfusing, we do the compatibility testing. So before transfusion of blood or its components, it's also essential to know whether they are compatible with the recipient's blood. And this is achieved by performing a set of procedures known as the compatibility testing. Sometimes the term compatibility testing and cross-match are used interchangeably, but cross-match is only part of this compatibility testing. I think that is clear. Compatibility tests include, we have to review our patient's past blood bank history and records. If they have been transfused before, we have to review. Then we do their ABO and rhesus typing of the recipient and also the donor. We also do the antibody screening test of the recipient and the donor's serum. We also do the cross-matching. So what is cross-matching? Cross-matching is also very important before any blood transfusion. Cross-matching should be carried out to ensure that there are no antibodies in the patient's serum that will react with the donor's cells when transfused. So, what is the importance of this cross-matching? It is the final check of the ABO compatibility between the donor and the recipient. So it's important in a way that it detects the presence of any significant unexpected antibodies in the recipient's blood that will react with the donor cells, thereby preventing any transfusion reactions that we are going to discuss later on. So a thorough cross-matching is performed with recipient serum and donor red blood cells. So we have types of cross-match. We have a major and a minor cross-match. So a major cross-match consists of mixing the donor red blood cells with the recipient serum. So here we mix the donor red blood cells with the recipient serum. Whereas in the minor, we are going to mix the recipient's red cells with the donor's serum. So the reverse occurs. So for the major cross-match is the simplest method we can use. So we place one drop of the patient's serum in a pre-labeled glass test tube, and then we add 5% saline suspension of the donor red cells to that test tube. Then we mix them and incubate at body temperature, 37 degrees Celsius, for 30 minutes. Then after we centrifuge at 1,000 revolutions per minute for 1 minute. Then we examine the test tube for agglutination or hemolysis. So if there is no agglutination or hemolysis, that will indicate compatibility. Then you can go ahead and transfuse. Then if there is agglutination or hemolysis, that will indicate a mismatch and the recipients should not receive transfusion if there is agglutination. So for the minor cross-match, it can be carried out by taking one drop of the donor's serum and one drop of 5% saline suspension of recipient's red cells. Then you incubate at 37 degrees Celsius for 30 minutes, centrifuge at 3,000 revolutions per minute for 1 minute. Then you observe for agglutination or hemolysis. It's always necessary to monitor the recipient during and after transfusion. This is very important, people. It's important to monitor the recipient during and after transfusion so that any complications can be managed accordingly. So in our practice, if we transfuse blood, we should not just transfuse and go sit on the counter or wherever. We should first be there for a few minutes and observe our patients for these reactions. Yes, I think at this juncture, let me call upon my co-presenter, Abhinava, to continue with the presentation. Thank you for listening.
The first component that I separated was our red blood cells that gives our first product, that is your packed red blood cells, which is very important in cases of anemia and everything, as my colleague took you guys through and in a very good way. So that's the first blood product, easy to remember, packed red blood cell. So now what is remaining in our test tube? It is having the platelets and your plasma. So now this is what we call your platelets rich plasma. Again, let's remove, we separate platelets and plasma. How do we remove platelets and plasma? You can basically freeze this platelet rich plasma, which will remove all the platelets and just keep your fresh frozen plasma. So this is your second blood product, which is your fresh frozen plasma, and the third product, which is your platelets. So you started with the whole blood, you removed the red blood cell, you got your packed red blood cell, you kept your platelets and plasma, you froze that platelet rich plasma, you got your fresh frozen plasma and your platelets. Let's further divide it. Let's further take this fresh frozen plasma and further divide it into two different parts. As my colleague had said before, that a fresh frozen plasma consists of all clotting proteins. But what if we just want some coagulating factors or just four major clotting proteins? In that case, or three clotting proteins, for that, what we do, we fractionalize these proteins. We remove certain clotting proteins from this fresh frozen plasma and just include factor 2, 7, 9, and 10. So that will give you your 4 factor prothrombin complex concentrate. And further, if you remove factor 7, then you'll have your 3 factor prothrombin complex concentrate. And if you guys remember, the reason we are removing, even if, like, there is a natural question that I also asked, that if we have all clotting proteins, why should we further fractionalize and remove the clotting proteins so just the 4 is remaining? So for that, I'll take you back to your blood pharmacology, in which we had learned about warfarin. And if you remember, in warfarin, we had talked about that warfarin's mechanism of action was to inhibit vitamin K epoxidase. So once it inhibits that vitamin K epoxidase, all the clotting factors that require vitamin K to activate, and that are factor 2, 7, 9, and 10, those all will decrease in our blood. So the reason we are giving this particular, just this 4 factor prothrombin complex concentrate, is for just substituting the clotting factors that were removed due to the warfarin toxicity. So that's why we fractionalize the protein. And further, as we know, we froze the plasma. Now we unfreeze it, as in we thaw the fresh frozen plasma, and then we'll get our cryoprecipitate that consists basically of your fibrinogen. So that's how you can remember that what are the blood products. You started with whole blood, you started removing each component. You started to remove your red blood cell, you got your packed red blood cell. You removed your platelet and plasma, you got your fresh frozen plasma and platelet. And again, from your fresh frozen plasma, you fractionalized the proteins and you got your prothrombic complex concentrate and your cryoprecipitate. So that's how you can remember what are the blood products that are available. So the reason I took you through all of these blood products is to tell you guys that we cannot just directly give this blood products to any patient. There is certain guidelines, there are certain rules that we must follow. And for knowing that rules, you first need to know the principle of ABO blood group that was given to us by Landsteiner, which we saw in your previous slides. So starting with your ABO groups, we first need to know that for determining your ABO groups, it depends on the immunological reaction between the antigen and antibody. So now, as we remember, I think so from our first years, that antigen are present on the surface of red blood cells, and there are majorly two antigen. There is an antigen A and antigen B, which are also called as your agglutinogens. And the reason they are called agglutinogens is because of their capacity to cause agglutination of red blood cells. That basically means packing of red blood cells together and cause a major side effect of hemolysis if it worsens. Then, as we know, the corresponding antibodies will be now called as agglutins. These are present in your plasma and they are majorly two. There is an anti-A or alpha antibody and anti-B or beta antibody. And then there are particular agglutinogens, and the corresponding agglutin cannot be present together because of the clumping of blood will occur. So basically, that means that if a person has A antigen, that does not mean he will also have alpha antibody in plasma. because that just ensures that there will be agglutination occurring in that person. So that's basically the meaning behind this line. Then, as I said, Karl Landsteiner classified the blood groups. Later, it became the Landsteiner law for grouping the blood group. And that's when we'll go over to our next slide. What does Landsteiner law says? So, Landsteiner's law says that if a particular agglutinogen, which is basically your antigen, is present in the red blood cell, the corresponding agglutinin antibody must be absent in the serum. The direct logic for this is that, for example, if you have A antigen on your red blood cell, there won't be an anti-A or alpha antibody in your plasma. Because if both of them are present together, that means the alpha antibody will react alongside with the A antigen, leading to antigen antibody reaction, which will cause hemolysis in our body. And as it is not occurring in our body, therefore this law proves that there is not a chance of having both of them together. Then the second law says that if a particular agglutinogen is absent in red blood cell, the corresponding agglutinin must be present in the serum. So basically, it says that if your A antigen is present in your red blood cell, that means the B antigen won't be on it. So if when the B antigen is not in your red blood cell, that means you have anti-B or beta antibody present in your plasma. That's the logic behind this statement. And then for and yeah, being an except the second statement has an exception is that it is not applicable for ruse factor. The ruse factor is first apply. I think so. The name ruse comes from the fact that it was first obtained from a ruse monkey, and you guys may remember it as like A positive or B positive. So that positive suggests that the person has ruse factor present in it or is Rh positive. So, moving ahead with this antigen and antibody present in ABO groups, this is basically in a tabulated form, as I said, that what is present. Like a person is told to have an A group or A blood group if he has A antigen in his red blood cell and has anti B in his red blood cell. So, this says of your first law of Landsteiner, and this proves the second law of Landsteiner. Then you have blood group B. Similarly, blood group B, that means you have B antigen in red blood cell and anti-A or alpha antibody in your serum. And AB means you have both A antigen and B antigen in your red blood cell and you have no antibody in your serum. And lastly, you have group O. Group O means there is no antigen in your red blood cell. There is no A or B. That means both the antibodies will now be present in the serum. Moving further, that how do you determine ABO blood group? So for the determination of ABO group, it is also called blood grouping or blood typing or blood matching. And the principle of blood typing is agglutination. Basically, antigen antibody reaction occurring, the antibodies in plasma will react with the antigen present on the red blood cells. So, blood typing is done on the basis of agglutination, and agglutination occurs if an antigen is mixed with its corresponding antibody, which is called as isoagglutinin. For example, agglutination occurs when A antigen is mixed with anti-A or when B antigen is mixed with anti-B. So now this tells us the process of blood typing, which we again did in our first year, first semester. And I think so most of us will remember this thing because I remember, at least for my group, very vaguely, everyone was ready to give blood on that day because everyone wanted to know what was their blood group, or they wanted to know if the lab guy had predicted his right blood group or not. So I'm kind of confident most of you guys will remember this experiment that we did, in which we used to take blood sample. It was basically one of our colleagues' blood sample we will take that had red blood cells in it. Then we'll take reagents that are used, such as antiserum A that had anti-A or alpha antibody, then antiserum B, which has either anti-B or beta antibody. And the procedure is simple. It's first of all saying that you take one drop of antiserum A and place it on one end of a glass slide or a tile, and then add one drop of antiserum on the other end. Then in each of that, you add one drop of red blood cell suspension that is mixed with it, each antiserum, and then the slide is slightly rocked for 2 minutes. Now, if the agglutination is occurring or not, that can be seen in those small holes or in that glass slide that we put in. And that tells that this presence or absence of agglutination helps us determine your blood group. So absence of agglutination is confirmed by a clear mixture with dispersed red blood cell. And then finally the results. If agglutination occurs with antiserum A, that means the antiserum A contains alpha antibody, and the agglutination occurs if the red blood cell contains A antigen, telling us the blood group is A. Secondly, if agglutination occurs with antiserum B, that means that antiserum B has beta antibody, and the agglutination has occurred if red blood cell contains the B antigen. So this proves that the blood group is B. And for similarly for agglutination, if both anti-sera and anti-sera A and B agglutination has occurred, this means that RBC has both A and B antigens that causes its agglutination, and hence the blood group is AB. And if agglutination does not occur either with antiserum A or antiserum B, the agglutination does not occur because that blood cell does not have any antigen on its surface. Hence the blood group is O. And if you guys who have not remembered now, I think so you remember it now, that you can see here that this patient has alpha antibodies in plasma, therefore you have agglutination here, and no agglutination here because it does not have anti-sera B or beta antibody, therefore the person has blood group B, and so on for the rest of the procedures. Then Roos factor, as I said, Rh factor is an antigen that is present on the red blood cell. And as I said, the antigen was discovered by Leinsteiner and Wiener. It was first discovered in a Roos monkey, hence the name Rh factor. There are many Rh antigen, but only D antigen is more antigenic in human. The person having D antigen are called Rh positive, and those that do not have D antigen are called Rh negative. And as I was an Indian and Charity was Ugandan, we bought both of the population, and in this we saw that among Indian population, 85% of them had Rh positive and 15% had Rh negative, whereas the percentage of Rh positive was more likely present in black people. Now, RH group system is different from ABO group system because the NTGD does not have any corresponding natural antibody. We do not have an anti-D in our plasma. That's what they are trying to say. And hence, the second law of Landsteiner, which stated that there should be a corresponding agglutinogen or corresponding antibody if the person has if person does not have the specific antigen or a red blood cell. But here, as we do not have anti-D, the second law of Landsteiner does not is not applicable here. However, if Rh positive blood is transfused to a Rh negative person, anti-D is developed by the immune system of that person. And on the other hand, there is no risk of complication if a Rh positive person receives an Rh negative blood. Moving forward, now, as I said, the ABO blood group is one important thing. It is one thing that we must know before transfusing this blood products into different patients. But there are certain group of patients in which we, even after knowing the blood group, we cannot just directly give the blood. We cannot give this blood products into this people. The reason being that there are certain group of people that might not be having proper immunity or are suffering from certain immunodeficiency diseases, and in those group of people we have to be very careful when we are giving this blood products. In order to do that, we'll have to first modify our blood products. We'll have to further modify it, such as if it's packed red blood cell, we'll have to either do irradiation or leukoreduction or washing into it before giving to that particular group of people or that particular population. So what type of modification that can we do in our blood products? There are three major modification that we can do, and it's very simple. We can do irradiation. Irradiation is basically, as the name suggests, we will expose this blood products to certain radiations. Either it can be X-rays or gamma rays, etc. And why are we doing this particular modification? We are doing this to decrease the number of T cells that are present in donor blood. T cells are basically your T helper and T cytotoxic cells, your T helper and TC being your T cytotoxic cell, which is T4 and T8 cells. And do we need to reduce this? Because if in certain group of people, if we give this donor blood, the donor blood will release its T cells, and this T cells will release certain cytokines and certain uh, hemolytic components into your recipient's blood, which can lead to antigen antibody reaction in your host tissue, and that what we call as your graft versus host disease. Certainly, these people usually will come with clinical features just after the transfusion of either maculopapular rash, first attacking the skin, or it can attack your bone marrow, leading to pancytopenia. Then it can also affect your liver and spleen, causing hepatosplenomegaly. And in the GIT mucosa, it can also disturb the GIT mucosa, leading to diarrhea. Hence, the major persons that are required to give irradiation of blood products before giving them blood products are those that have just had a bone marrow transplant, or have any hematological malignancy, such as leukemia, etc. Then, yes, doctor.
Okay, the most, all you said is right regarding the HLA, human leukocyte antigen. You know that is the antigen that is responsible for tissue rejection and those reactions that follow transplants. A transfusion is a transplant. The most common or something you may come across as a doctor is the lung injury. Okay, the lung injury which may follow such a reaction, transfusion related acute lung injury. So let everyone read about how it's recognized and how it is managed. Transfusion related acute lung injury, TRALI. Okay, you can continue, please.
Okay. Thank you so much, doctor, for that. Okay, so continuing with the second modification that we can do is known as leukoreduction. As the name suggests, when we say leukoreduction, basically we are reducing the white blood cells that are present in donor's blood. And the reason we need to do this to decrease white blood cells in the donor's blood is because sometimes this this donor's blood once goes into your transfusions. Whenever they are transfused, these white blood cells can attack the recipient's tissues and can lead to the risk of this FNHTR, which I will tell this in the complications when in the further slides there are complications of blood products in which there is febrile non-hemolytic transfusion reaction, and also it can also lead to a condition known as cytomegalovirus. That is, I think so, that is herpes complex 5. And then, as I know, the indication is that if a person has a history of blood transfusion or is at risk of an HIV associated infection. Then the third major modification in blood product is washing. Washing, I think so, this we did in immunology, in which there was one particular deficiency, the IgA deficiency. In that, we had learned that in a person who is IgA deficient, whenever blood transfusion is occurred, always wash the red blood cell or wash the blood. The reason we do washing of the blood is to remove the proteins or the immunoglobulins that are present in donor blood. Because remember, this IgA is not present in the recipient. So even though it being an immunoglobulin, this IgA for the recipient's immune system will be known as an antigen. Even though we know that it is something good for us, it is a antibody, but as that antibody is not naturally produced in the recipient, that IgA will be known as an antigen and will lead to an anaphylactic reaction, which I again will tell in detail when we come into the complications of the complication of different blood products or blood transfusion. So those are the three major modifications that I came across: irradiation, leukoreduction, and washing. Then Moving further, this complication are usually general, such as this hemolytic reaction, non-hemolytic febrile reaction, allergic reaction, transfusion-related acute lung injury. As our doctors say, that it is very important. We go through this. I have some things in our slide, but I think so. This, as our doctor said, we'll go much more in detail about this. And then also reactions secondary to bacterial contamination, circulatory overload. This is also there in the slide. Air embolism, thrombophlebitis, hyperkalemia. This is very important in those persons that are on certain diuretics or have any presenting ECG changes. Then citrate toxicity, then hypothermia and clotting abnormalities. This is usually seen within 6 to 24 hours. Late occurs around, this takes around weeks to days to be seen. These are basically transmission of infection. It will either be viral infections such as hepatitis A, B, C, or HIV, or as I said, cytomegalovirus. Then bacterial such as Treponema, Palladium, syphilis, basically. Then certain parasites such as malaria and toxoplasma. And also graft versus host disease, as I say. Then iron overload and immune sensitization. Then moving further, the special types of complications that I came across and I thought it is good for us to go through. And the one of the most commonest of all of this complication that I heard is this febrile non-hemolytic transfusion reaction, or FNHTR. So the major cause or the pathophysiology of this is that yes, as doctor said, that there is anti-HLA antibody, and if this donor's blood, whenever we give this donor's blood to the patient, now in the patient, in our recipient's body, there is plasma anti-HLA body, and this plasma anti-HLA will go and bind to the donor WBC. It will bind to your donor WBC. It will activate that white blood cell to release cytokines. And when it releases cytokines, these are usually TNF alpha and interleukin 6 and also sometimes interleukin 1. And all of them will go and stimulate the hypothalamus, and that will give us this clinical features that I wrote. It will give a rise in body temperature. It will show fevers and chills. So, who are the patients that are maximum risk of this FNHTR? Are those patients that have a history of previous transfusion? Because logically, think if a person has already transfusion, that means that blood is recognized by the immune system of that person, and now that person's immune system would start to form this antibody against the donor WBC. So this antibody will go and stimulate the hypothalamus, and hence give us this complication of febrile non-hemolytic transfusion reaction. Second, most important is that the children are at the maximum risk of this febrile non-hemolytic transfusion reaction. Then lab test. See the title. It is written non-hemolytic. That means there is no hemolysis of red blood cell. So if the hemolysis never occurred, that means because whenever whenever the red blood cell is hemolyzed, or whenever any tissue undergoes destruction, it will release certain components of it into the stream. So now, as the hemolysis have not occurred, that means the person's lactate dehydrogenase or LDH is normal. Haptoglobin is normal. Haptoglobin is present in the serum. Whenever a red blood cell undergoes hemolysis, it releases hemoglobin, and that hemoglobin will be present in the serum. So now, as the hemolysis have not occurred, that means the person's hemoglobin would stay in hemolytic reaction. But here, as there is no hemolysis occurring, the haptoglobin is normal. And also this Coombs test is basically a test in which we give already an anti-antibody, then an antibody, and the red blood cells of the patient, and then we test for specific antiglobulin, because there are two types of Coombs test. There can be a direct antiglobulin test and indirect antiglobulin test. When we are looking for specific antibodies, do remember we had did this for I think so malaria. It is one of the lab works you can do for malaria for looking for Duffy antigen. That is responsive, that is present within the blood. which the plasmodial species react with, with the red blood cell of the patient suffering from malaria. Then for the treatment, I have came across, you stop the transfusion immediately. You do not transfuse that person now and give him antipyretics for fever, which are basically your NSAIDs. But in NSAIDs also those that are such as paracetamol that works at the level of brain itself. And as I said, for prevention, you do leukoreduction. You remove the WBCs, because if you remove the WBCs from the blood products of your donor, once you give this donor blood to the recipient, again, these antibodies do not have an antigen to react with. And when there is no antigen to react with, what there will be no antigen antibody reaction, and hence we do leukoreduction. This is one of the major indication for modification in blood products. Leukoreduction is usually a modification of choice for patients with febrile non-hemolytic transfusion reaction. Then there is hemolytic transfusion reaction. There are two major types of hemolytic transfusion reaction. There is an acute and delayed. The major difference being that acute we usually is seen within 24 hours, whereas the delayed hemolytic takes from weeks to days to occur. So if I start with acute hemolytic transfusion reaction, the most important risk factor of it is ABO incompatibility. So now you know why we talked about ABO blood group, Lanssteiner law, Rh positive, everything. Because if we do not do this, and if a person just gives any incompatible blood that we saw in the very first history, I think so it was 1617, which Pope had taken blood from three little boys and all of them died, it most probably will be due to this ABO incompatibility. The reason being that whenever there is a mismatch of a blood type, so for example, you give B positive blood to an A positive patient, the patient's antibodies, which is anti-B, will bind to your donor's red blood cell antigen, which is B antigen, and that it will cause antibody antigen reaction or agglutination inside the circulation, hence it's called intravascular hemolysis. And this hemolysis of red blood cell, now you know, I have disturbed the red blood cell. Now the red blood cell will release all its products into the circulation. So first thing it releases is the lactate dehydrogenase. So you will see that the person has high LDH. Second, he will also release hemoglobin. Now this hemoglobin can do one thing. It can bind to your haptoglobin and decrease the serum haptoglobin concentration. Third, the hemoglobin can undergo further metabolism and convert into heme and globulin. This heme again by a biliverdin, I think so biliverdin synthase, it can convert into biliverdin, and then biliverdin reductase converts it into bilirubin. And this bilirubin, in lab findings, you'll see this high bilirubin. And as we know, this bilirubin is usually deposited first in the sclera of the eye, then rest of the body, leading to yellowing of the sclera and the body, hence the clinical feature of jaundice. But for acute hemolytic transfusion reaction, usually it is seen that majorly cytokines are released in the first 24 hours. Majorly cytokines are released, and this cytokinins have two major functions. It will go to your hypothalamus and again give you this fever and chills. It can also go to your circulatory system, and once in the circulatory system, it is a potent vasodilator. And once you do vasodilation, you decrease the systemic vascular resistance. Hence, you're decreasing your blood pressure. Hence, the person can go into hypotension. And the second thing, due to it going into vasodilation, it also causes capillary leak. Now, the products of your blood is starting to leak into the peripheral tissue, leading to edema. And a very important, or I think so, I found it very interesting is that this hemoglobin can also move to your nephron, and in the nephron, it can cause tissue lysis of your proximal convoluted tubule. Primarily, the epidermal, not epidermal, sorry, the epithelial tissue of your proximal convoluted tubule can undergo lysis, and this hemoglobin will be released in urine, hence causing hemoglobin urea. It will also decrease the urine output, which is known as oliguria or N-urea. And also, due to the tissue destruction, there will be high creatinine level in the urine. And all of this are indication of acute kidney injury. Hence, I'm also telling the clinical features I wrote and the explanation of why these clinical features are seen. And the treatment for acute hemolysis is usually you just stop the transfusion and you give supportive treatment. Supportive treatments means you treat the symptoms, such as for fevers and chill, you give antipyretic. Then for hypotension, you give certain cardiac medicines, etc. And as I said, for delayed hemolytic transfusion, the major pathophysiology for delayed hemolytic transfusion is not to do with ABO blood group incompatibility, is rather antibodies are present against specific antigens against the red blood cells. This usually is occurring after, this does not is not usually seen in the first transfusion itself. Like you went for a transfusion and immediately you got hemolytic delayed hemolytic reaction. It is usually seen on the third transfusion, because on the first transfusion usually does not anything occurs. On second transfusion, the patient will now form antibodies against specific antigen. For example, if I have to say a specific antigen is like a Duffy antigen, you remember red blood cells also have their own other antigens other than A and B. It can be also against Duffy antigen, specific antibodies formed by your immune system. And on the third time, when you again give this blood to your donor, you will see that the person has once again there will be antigen antibody reaction, but this reaction will be extravascular. Extravascular means it majorly occurs in spleen and in liver. Hence, you can see why the person has splenomegaly in its clinical feature and also jaundice in its clinical feature. And hence, the person also can release certain cytokines which can stimulate your hypothalamus, causing mild fever, and sometimes dark urine may also occur. And I told you why the laboratory findings is why they have high bilirubin, high LDH, and less heptoglobin. I told you the just to put a light again, basically due to hemolysis, there will be bilirubin increase, LDH decrease, and the heptoglobin will bind to your hemoglobin. So the free serum heptoglobin concentration decreases. Treatment for this is usually you first stop the transfusion immediately and you give supportive treatment. Then this were the two. Then the third, yes, the third one, the allergic and the anaphylactic reaction. For allergic reaction, we have come across basically what happens in allergic reaction is when you give donor's blood is transfused into the patient has certain plasma proteins present in it. The plasma proteins will recognize the this plasma proteins are recognized as antigen by the plasma B cells of your recipient or the person who's taking the blood, and that will release IgE antibody. This IgE antibody will bind to your antigen, and this antigen will go and bind to your mast cells that are present in your circulation. These mast cells will then release three major products such as histamine, prostaglandin, and leukotriene, but the most important one is histamine. Histamine is a potent vasodilator and will cause capillary leak, due to which you will have clinical features of urticaria, which is basically known as hives. It is somewhat like hives. And the second feature of pruritus or itching. So treatment will be to stop the transfusion and give antihistamines, because as I told, the mast cells majorly release histamine. So you give antihistaminics for mild reaction. And then you monitor the patient that the patient does not go into anaphylaxis. And as I said, for prevention, you can give washed RBCs, but the major treatment of choice or major modification for washed RBC is when we use in anaphylactic transfusion reaction. Now, in anaphylactic transfusion reaction, as I said, the major risk factor being the IgA deficiency. You give a person that has IgA antibody. The donor has IgA in his blood. You give it to the recipient that is IgA deficient. The recipient's immune system would identify the IgA as a antigen and will release IgE against it. There will be IgE, IgA complex, and they will go and bind to the mast cell. Again, they will release high histamine, but this time it will be much more. It will cause much more reactions. It can cause, first of all, it will cause urticaria, as I said. It will also cause pruritus or itching. But here the things become a little dangerous and also life-threatening, because they are also responsible for causing bronchospasm that will lead to wheezing, dyspnea. They will also cause capillary leak, which can cause laryngeal edema, and a major thing of angioedema. Angioedema is usually occurs in the eyes and in the lips. You'll see they have swollen, high swelling has occurred at the eyes and the lips. You see in the children sometimes they will not be able to even open their eyes. That much the edema would have been present. And the treatment for this is, again, you stop the transfusion and you give IM epinephrine. As we know, epinephrine is a sympathomimetic drug. It will go and bind to the beta 2 receptors. It will stimulate the beta 2 receptors in your bronchioles and will cause bronchodilation. And as I said, for prevention, you give washed red blood cells. You wash the blood that does not. You remove all the plasma proteins, especially IgA, so that this anaphylactic reaction does not occur. Then the other major reactants, the one that doctor said about the transfusion-related acute lung injury. What I was able to gather from this is still very short. I think so. We should definitely go and read about this more. But the understanding I got for TRALI, or transfusion-related acute lung injury, was that usually the donor don't get. I know I'm taking a lot of time, but yeah, do not do not get confused, because when we say anti-HLA in the recipient, that is the FNHTR, febrile non-hemolytic transfusion reaction. And when I say anti-HLA in donor, that's when comes the transfusion-related acute lung injury. So basically, this is usually a two-hit model. At the first hit, all the neutrophils of the patient will sequestrate around the lungs. All the neutrophils will be present around the lungs. Then, when you give the donor blood that has anti-HLA or anti-neutrophil into the recipient, this anti-neutrophil will go to the neutrophils which are present near the pulmonary capillary, and then it will activate the neutrophils, and this neutrophils will release high amount of proteases and reactive oxygen species, which will cause pulmonary capillary damage. And this pulmonary capillary damage will lead to fluid deposition in the lungs. So this is occurring because of antibody present in the donor's blood. It has nothing to do with cardio. It is nothing to do with the cardiac element, or anything to do with the heart or the circulation per se. So this is known as a non-cardiogenic pulmonary edema. So the patient's clinical feature is usually like acute respiratory distress, or ARDS for short, in which the person has hypoxemia, of course, because the pulmonary circulation is broken. There is no appropriate diffusion of oxygen. On X-ray, you will see bilateral pulmonary infiltrates, and there is no evidence of circulatory overload. And dyspnea, the person has difficulty in breathing. For treatment, you usually stop the transfusion, you give oxygen to treat the hypoxemia, ventilation if required if further hypoxemia has occurred, and supportive treatment to treat these acute respiratory disorders and or any other complication that might occur. For prevention, as I said, you use appropriate leukoreduced blood components so that the person does not usually go into again this Charlie cannot be seen again. Then just opposite to it is TACO, that is transfusion associated circulatory overload. The major risk factors for this are usually the elderlies and children, but the most person that are in risk are those that have fluid retention disorder. Fluid retention disorder means they are not able to excrete or remove the fluid in your circulation nicely, such as those that have heart condition, that have heart failure or coagulative heart failure with reduced ejection fraction, or those that have end-stage renal disease, due to which the circulation, the fluid is usually pulled in the circulation only. So in these people, what usually happens is that if you give sudden and high blood into this patient, there will be a very high blood volume. They will undergo hypervolemia. These patients will undergo hypervolemia, and which what will affect that? That will affect the central venous system. Due to high blood volume, there will be high end diastolic volume. High end diastolic volume means high system. The stroke volume. High stroke volume means high cardiac output. High cardiac output means high blood pressure. So the first major thing, as I said, hypertension. If high blood pressure is, that means with a very high velocity, the blood is coming into the ventricles. So now the ventricle has to work twice as more in order to push the blood into system. So there will be increased heart rate. So this is the second clinical feature of tachycardia. Then second, if the person has high ventricular filling, we know that there are majorly two heart sounds that are normally heard, S1 and S2. But due to ventricular rapid filling, there will also be heard a S3 gallop, will also be heard. Third, due to high ventricular filling, that means the pressure has changed. Now the pressure is more in the heart and less in the central venous area. So now there will be backflow of the blood. The blood will start to pull in the venous system, which will increase the central venous pressure. And when the central venous pressure will increase, it will move back to the jugular vein and cause jugular venous distension. So there will be jugular venous distension, which can be seen as raised JVP. It can also go to your femoral veins in your lower limb and can cause pitting edema. And at the same time, there can be also increase in the pulmonary capillary wedge pressure, which will lead to pulmonary edema. And for treatment for this is usually stop the transfusion and give diuretics. Give diuretics such as furosemide, which is a loop diuretic, to remove excess amount of fluid from your circulation. And when you remove this excess circulation, you will basically decrease all these clinical features that we are seeing. Other than that, this jaundice, cardiac shock, renal shutdown, these are individual complication that might occur. But I think so. I've covered all this when I talked about the pathophysiology. Then there is, yeah, there is massive blood transfusion. That is also one of the major complication. This is basically whenever you give high amount of specific blood products, such as you give packed red blood cell. Once in the circulation, this red blood cell will release high amount of potassium, causing hyperkalemia. Then this red blood cell also consists of citrate. The citrate will bind to the calcium and decrease the calcium content in your blood, hence causing hypocalcemia. Then it will also cause increased deposition of iron, and this the iron deposition occurs in the form of hemosidrine, hence causing hemosidriosis. Then it can also cause circulatory shock. And one important thing is that, for example, you just give packed red blood cell to a person that is undergoing this. If due to you give a transfusion of only packed red blood cell, that means you are further diluting only the person's circulation with only red blood cells, which can further decrease the amount of platelets and the plasma which is present in the patient's circulation, which can worsen coagulopathy. And other than that, you need to know the guidelines that you need to know for blood transfusion. And this are basically saying that a medical practitioner must prescribe a blood transfusion. The prescription must state the blood component, what you are giving, is it packed red blood cell, platelet, or plasma. Then the volume to be transfused and any special requirements, such as I said, the modification, either irradiation, washing, or phenotyping, or leukoreduction. Then, if necessary, instruction must be given regarding the speed of transfusion. As I said, rapid transfusion of blood at once together increases the risk of transfusion associated circulatory overload. To prevent that, we need to know what is the speed of transfusion we should give. Then the possible need to warm the products or any other factors to be considered. For example, the patient's condition, unless the staff has issued relevant protocols already. Then, if the patient has significant cold agglutinins, the red blood cell should be warmed during transfusion using an approved commercial blood warmer. Then, other guidelines is that the person carrying out the transfusion must check the prescription and ensure that the red cells packs intended for transfusion have been found by the laboratory. Compatibility test has been done. You do the ABO compatibility, because if you do not do that, the person might go into FNHTR. The patient will go into FNHTR, sorry for the language. Then, before a transfusion of red cell, you need to check the results of compatibility testing and verify that the correct product and patient was used for the test. The donation number on the blood bag label must be exactly matched for the number of accompanying documents. They must indicate the compatibility of the unit. And if the patient has red cell antibodies, ensure that the label on red cell pack states the absence of antigen corresponding to the antibodies. Basically, this being the reason why we went so much into ABO blood group. Then, further continuing, the blood product must be checked for defects such as integrity and cleanliness of the bag, presence of clots, etc. Then the confirmation that the checks have been carried out and is done by signing the transfusion form. The blood administration set within the integral unit of 150 to 200 micrometer filter, and appropriate attached to the pack to be transfused should be used to transfuse all blood products. Then always verify the patient's identity. The patient's identity data must be checked against the data of the blood products. The patient is asked to state his or her identification or details, or a person familiar with the patient verifies the identity. So we do not give wrong blood product to the wrong patient. And before starting the transfusion, the patient's vital signs such as heart rate, blood pressure, temperature should be checked and recorded. The start time of the transfusion must be also recorded, and the sticker of the blood product label indicating the unit number should be detached and reattached to the patient's notes, or the transfusion is entered into the electronic patient record system, and the recording is carried out to fulfill the statutory obligation to ensure that we have given this blood product. This is for our own well-being, that the hospital has given this blood product and we can trace it. Then the same administration set may be used to transfuse several pack of red cells without interruption, but it is recommended that the administrator set is changed after 6 hours in order to reduce the risk of bacterial contamination. Basically, if you keep one red cell continuously and give it to a patient for more than 6 hours, there's a chance that the bacteria may infiltrate that cell and then form clots or further cause infection in the patient. And it is recommended the platelets are administered via separate administration or they be transfused first. If the transfusion is continued with the red cell, if the tubing is red cell, retention of platelets may also occur. And lastly, concluding it, I'll give you a small mnemonic how to remember all the blood transfusion. Even though it is not advisable that we use mnemonic, especially in clinical years, but still, if you want to know how all the complications or major complications that can occur, you have a fever halo. Fever basically giving you the febrile non-hemolytic transfusion reaction. H stands for the hemolytic transfusion reactions, that is acute and delayed. A stands for allergic and anaphylactic reaction. L stands for lung injury, that is the transfusion related acute in the acute infusion lung injury, and O stands for TACO, which is transfusion associated circulatory overload. And with that, this is the references I have, which we took. Some I took from